Previous studies have, previous phase 2 trials have shown that you can safely combine apalutamide with ADT in biochemically relapsed prostate cancer. And we've previously seen in a phase 2 trial that that does not negatively impact quality of life and may lead to prolongation of PSA progression-free survival, although the prior studies were not powered to really detect for those differences. Similarly, there have been phase 2 trials with abiraterone in the biochemically recurrent setting, showing similar effects on PSA. There's not been a previous study that tested the triplet of abiraterone, apalutamide plus ADT in biochemical relapse, so that was one of the unique features of this study. So in terms of the rationale, we know that intensifying ADT with the addition of an oral androgen receptor blocker, whether it be abiraterone or apalutamide, has shown to improve outcomes in other disease settings, including metastatic castration-sensitive prostate cancer, metastatic castration-resistant prostate cancer, non-metastatic castration-resistant prostate cancer. So I think there was pretty strong rationale to test the hypothesis that intensifying therapy improves outcomes in hormone-sensitive biochemical relapse disease, and that was really the intent of the study. It was a randomized phase 3 open-label trial. 3 arms were investigated. The control arm was ADT alone, given for a finite period of 12 months as part of an intermittent therapeutic framework, and that's one of the standard of cares in this setting. And there's 2 experimental arms. One was androgen deprivation combined with apalutamide, and the third arm or second experimental arm was the triplet, ADT plus apalutamide plus abiraterone with low-dose prednisone. In all 3 arms, patients were treated for 12 months and then stopped, and that's important. We think of intermittent therapy as really the standard of care when we're giving systemic hormonal therapy. And we subsequently designed the study to look pragmatically after we stop therapy, how long does it take for the PSA to recur? What does that PSA progression-free survival look like? Because in clinical practice, that often dictates next steps in terms of imaging and further therapy. So PSA progression-free survival was chosen as the primary endpoint for that reason. We defined PSA progression-free survival using a pretty stringent cutoff of any PSA value greater than 0.2 nanograms per milliliter, which is the definition of biochemical recurrence in patients who have had prior radical prostatectomy. And we chose to use that kind of stringent definition even after systemic therapy in this setting, because that often serves as a trigger point to get further imaging and so forth and plan subsequent therapies. And we wanted to get that pretty clean readout of that endpoint, knowing that all patients had had prior radical prostatectomies, and therefore, there wasn't the confounding factor of an intact prostate gland. The main findings, we basically showed that both experimental arms compared to control, so whether it be the doublet of ADT plus apalutamide or the triplet, both statistically significantly prolonged PSA progression-free survival compared to ADT alone. And we showed that at the first interim analysis. So both analyses met the pre-specified stopping rule to really show efficacy for the combinations. There was a post-hoc pre-planned but exploratory analysis we did where we looked at triplet versus a doublet. The study wasn't really powered to answer that question, but nevertheless, we really did not see any differences between those 2 experimental arms. And that's consistent with other studies that have also not shown a benefit of triplet versus doublet therapy in other disease settings. So for us, one of the main conclusions is that intensifying therapy prolongs PSA progression-free survival, but you really only need the doublet of ADT plus apalutamide, not the triplet. We really did see a difference in toxicity, especially with the triplet. So as one might expect, we see higher rates of grade 3 or higher hypertension was one of the more common higher grade adverse events that we see really with abiraterone. In the doublet versus single agent ADT, there really wasn't a significant increase in the rate of grade 3 or higher adverse events, including hypertension. There was a slightly higher risk of skin rash, which was one of the known side effects of apalutamide. Those were largely low grade and manageable. So overall, the toxicity profile with the doublet looked consistent with prior studies and really looked fairly comparable compared to ADT alone. I think there's a number of important analyses still to be done. So from the current AFT19 PRESTO study, we are looking at longer term outcomes, including metastasis-free survival and time to subsequent therapy. Even though those were not the primary endpoint of the study, we think these are really important, clinically meaningful secondary endpoints. So follow-up is ongoing to really answer that question. We're just in the process of analyzing patient-reported outcome data and quality of life data from the study. That's really important. These are relatively early stage prostate cancer patients without symptoms from their cancer itself. So we really want to try to understand better what's the impact of hormone therapy on patients' quality of life and compare across the 3 treatment arms. So that data is forthcoming sometime this year. And then we know from other phase 3 studies, most notably the EMBARK study with enzalutamide plus ADT, that also has shown benefit, and they use metastasis-free survival as a primary endpoint. So I would argue that between our study and the EMBARK study, there's enough clinical data now and rationale to support intensification of hormone therapy as a new standard of care for biochemically relapsed patients that are higher risk, defined by short PSA doubling times and is meeting a certain PSA threshold for treatment.